Okay, we're live.
Hi everyone, welcome to today's shadowing session. We have an aesthetic and implant dentist, Dr. Kunal Rai, who will be sharing his experience and showing a case he has. So Dr. Rai, whenever you're ready, you can begin.
Good evening, everyone. It's a shame for some reason my camera is not working, so I'm sorry if you can't see me. But I'll go through this presentation that I've done for you guys. Firstly, thank you for Fresh Dentist having me on board today. So without delaying it, I'm just going to first start off by talking about myself. So I graduated in the year 2015 from Charles University in Prague. Especially, I just chose Prague because it generates opening for various countries. I'm from Leeds in the UK, so I could work in UK, America if I want to, certain states, obviously, Australia, so without giving another exam. I work as a general dentist, but I focus on aesthetic and implant work. 4 days in practice. I work 1 day on a Friday as a clinical teaching fellow, and I've just recently started doing some Invisalign teaching. Without boasting too much, I've been chosen as a finalist dentist for the year 2020-2021. However, I haven't managed to pass the last hurdle. I do post every now and then cases on social media. So if you can follow me on Instagram, it's at Kunal Rai _dentistry. Since qualifying in the year 2015, I've just not worked on my undergraduate degree. I've tried to hone my skills. I've done a 12 months PG postgraduate certification in restorative dentistry. What is restorative dentistry? Basically, crowns, veneers, occlusion, bridges, fillings, focusing on them. I've also done an MSc part-time, which I finished last June, in dental implantology with a distinction. I am just in my last month of my diploma in clear aligner therapy. This is basically Invisalign. Since when I qualified in the year 2015, as we'd have to do a year's residential in the UK, which we call the vocational training. I did it in a small town called Bridlington for 12 months. Thereafter, I've been in the capital of Haribo, Pontefract. And I started just working with the National Health, and I've slowly divided my time doing private work as well as the National Health. Alongside that, I have worked in Leeds out of our emergency clinics. Now, since I've worked in independent and corporate, I just want to give you a feel of what I think the difference is. There's no right or wrong, and everyone will have their own perception to this, but I'm just going to give you my thoughts. With the corporates, basically, these are led by the CEOs of these corporates are generally non-dentists. Each practice is led by a practice manager who is, again, may or may not be a nurse in the past, but they have been chosen as a practice manager. However, they come with a wide clinical support team. They aren't available extensively nationwide. However, they are profit-driven. But the advantage of working with a corporate is you do get discounts on various courses, tools, and equipment. Now, with an independent practice, these are led mostly by principal dentists. You have the clinical freedom because you do not have to answer to too many people. If you need any tools, you can just go to your principal dentist, have a conversation, and you can order them and start working with them. However, if you want to get any tools in a corporate, you need to get approval from your practice manager. Then he or she needs to get the approvals from the area manager, and they have to go from one hierarchy to another. So it takes a long time. It's less pressure because when compared to corporates, like I said, it's based on a business model, so it's profit driven. A drawback or a con of an independent is the fact that they are based locally. They are hard to find jobs. They are mainly a family team, small team, and the vacancy openings are less frequent. Now, my thoughts, advice based on my 6 years of being a dentist. This again, it's just my thoughts. It's not there's no right or wrong answer to it. But for me, since qualifying, I found that at university dentistry, what we get taught is basically a combination of art and science. But once you come to the real world, there is something else you need to add to this, which is business. You will need to have some kind of business acumen. Independent or corporate, you will have to work with some targets. You want to survive, you need to make some money, so you need to get that business skill in you. In your 12 months of residency, which may differ at your end, you may have to do less or more. You need to learn to start practicing to work efficiently and effectively. Being a clinical teaching fellow at the university, when I still see at the final years, I find them that they spend 3-4 hours on a single patient. But when you come to the real world, yes, you are giving your best to the patient, but at the same time, you are not generating any money for yourself or for the practice. So you need to learn how to become efficient and effective at the same time. So do you use your residency time to its full value, make the most of it. Now, another thing I found out, once you qualify with your undergrad degree, every dentist out there will have this degree, will have an undergraduate degree, maybe from a different country, but they all, to become a dentist, they need this degree. However, the basic degree on its own will not help you to become a better, will not help you with people in terms of making yourself a name. So you need to start to learn to invest to make yourself stand out. You need to hone in the area of dentistry you love. Like I had a big interest in restorative dentistry, so I went out there and spent more money in order to get better in the area of restorative dentistry, implantology, and Invisalign. You need to learn to be kind to others. You need to appreciate your team. As a dentist, you're not just working as your own. You need to understand that you're working in a team. So every now and then, like again, this is just an example. I go out and buy my nurse lunch or something just to show them the appreciation. Again, 6 years, I still have a mentor who I always fall back on if I ever need any help. If something I'm not clear about, I'll just ask them. Whether small or big, there's no harm in asking, no harm in falling back onto someone's shoulder to ask for some help. So just have a mentor in your career. Last but not least, communication is key. I was looking back at some old researches, and one of the indemnity in UK called DDU, they wrote down a very good article in which they said that most claims these days is based on due to lack of communication. So you need to understand that you need to, when you're presenting a treatment plan to a patient, or when you're doing something with the patient, communication is key. You need to step back from giving away jargon, medical terms, and just be simple terms. Avoid long sentences, just use terms that they can understand. Now, I'm going to move on to show you a case. Now, when a patient comes in to my surgery, the first thing I do is introduce myself, me and my nurse, ask the patient to take a seat. And the first question we ask is why they are here, what is in their wish bucket. And then we let the patient speak. We basically try to have an eye-to-eye contact. While they're talking, we nod so they know that we are listening to them. Again, every now and then I'll say I understand, so that patient feels appreciated, that we are showing some kind of empathy. Once from that, while in the background, my nurse is writing down the patient's main concern. So the case I'm going to show you in the patient's own word. Obviously, we have just cut it down to a few words here to fit it into the slide. When I was younger, I wasn't bothered. Now I'm in front of people and conscious of my teeth. I would like them to be straighter and whiter with shape improvements. So after going to the main concern, then the nurse and myself, we asked them about some basic history, like the medical history. In this case, the patient was fit and well, and we found out, we extracted from the patient that he has some allergies to penicillin. So in case we ever need to use some kind of antibiotics, we know from the outset that the patient has some penicillin allergy to avoid them. Social history, we found out that the patient is a web designer. So like I said, communication, we know that the patient is a professional. He has well educated, so we know the kind of terms that we can use. And since he comes from a non-medical background, we need to avoid the use of medical terms with him, just so that we don't confuse him, and everything is an implied consent. From social history, we also derive he's a non-smoker, he doesn't have any dependency on alcohol, and he has some minimal stress from his work. We also went on to the dental history. We found out that the patient uses electric toothbrush. Now, as I did an MSc, I'm quite keen into looking at evidence. All my work is evidence-based. Evidence out there today shows that electric toothbrush is 16% more effective in reducing the plaque from your teeth compared to a manual normal toothbrush. So it shows me here that the patient is already on the right track. He's quite already motivated. He uses the correct toothpaste, which is fluoride based. However, he only brushes once a day, which we need to change, which we need to get him to grasp the idea that once a day is not enough. He uses occasional use of mouthwash. However, he does not use any interdental aids. What you need to understand is our teeth is just normal. When you brush, you cannot just brush three. The brush only cleans three surfaces: the front, the middle, and the back. However, the teeth is made up of 5 surfaces, the in-between area, where the bristles cannot reach. So it's imperative that we use some, to reach the nooks and crannies of your teeth, you use some interdental appliances, which is such as interdental brushes, TP brushes, or flosses. We also look at family history so that we can derive if the patient has any kind of links coming from his parents, like gum disease. Thereafter, we went on to do a full oral examination. We started out externally. We checked for any bone deformation. We checked the lymph nodes for any kind of swelling. Swelling of the lymph nodes will indicate if the patient has some kind of infection or something untoward happening. We also check the mouth opening. Is there any problem with his joints, muscles? Then we move on to the internal part of the mouth. So we basically ask the patient to open wide, and then using light, we check the teeth, we check the pink tissue, which we call the gum, the tongue. With the tongue, we can derive of any kind of allergies, ulceration, sometimes you can also get some indication of lack of vitamins. You can also get some kind of, if the patient suffers from some condition. We also check the oral hygiene. And then we derive some key findings, such as which teeth have got some fillings, which teeth are missing. And then we check the health of the gums. The analogy I tell to our patient is that we want to ensure that the foundation is not based on quicksand. Like, you will never do an extension on your house on a quicksand. You want that foundation to be strong. And in this case, we want the gums to be strong. So that's why we need to do a gum examination. And as you wanted straight teeth, we did a full orthodontic review. We looked at the relationship of the upper jaw with the lower jaw, how the front teeth meet together, how the phalanges meet together, and how the big teeth meet together. Then we sent him for a full mouth X-ray. Why an X-ray? Just so that we can ensure nothing untoward is happening. As the patient wants braces, he wants to basically, bracing means moving teeth. We need to ensure there are nothing obstructing the teeth movement. We do not have any submerged teeth. We do not have any infection. If you look here, there's a bit of a shadow under this tooth, and this shadow indicates that there is a sleeping infection, which the patient was unknown about. So these things, incidental findings, can be seen on X-rays. That's why we need to do it. Now, since we've identified this problem here, so the option that we gave to the patient was, A, we can do nothing, leave it as it is. However, there's a risk that this infection could spread, lead to swelling, lead to pain, which it doesn't have at the moment. Treatment-wise, again, like I said, do nothing. Other option would be to remove the tooth. When we remove the tooth, so that's extraction. However, the risk with extraction is this tooth could drift, trying to block our path. This tooth could overgrow because there's nothing to hit it against, stopping it from over erupting. Alternatively, what we can do is we can keep the structure of the tooth, however, we can remove the content of the teeth by doing an endodontic treatment, which is also known as root canal treatment. And that is what the patient went for. You need to report your X-ray. So we did a full report of the X-ray. We graded its quality. We put down any kind of infection, any restorations, the level of the bone, if there was any kind of tartar built around, which we also call it calculus. Was there anything that was done through the lab? So in-depth restorations. There was no crown veneers here or bridges. Then we took some pictures, and this is what we just put in front of the patient, and we went through this. So we asked the patient, we took some smiling pictures, side view pictures. We can see here that the tooth is discolored. There are black marks to it. There is a chip on this tooth. The teeth are pointing outwards rather than inwards. We've got a big gap here, so it looks like he has got no back teeth. And on side profile, we can see some crowding. Proclamations are pointing not straight, but in an angle facing outward. And from all of this, we derived a problem list, which I generally divided into 4 categories. Aesthetic, the bite, which we call the occlusion, the teeth, which we call dentition, and the biology, which is the gum. So aesthetically, we made a list of the color of the shade, the chip in the tooth. We made a note of the black marks, of the narrow smile, which we call the buccal corridor, the tilting of the teeth. From the bite relationship, we obviously identified the crowding, which we mentioned earlier, the arch shape. When there's a smile design, an ideal smile an arch shape should be of a U shape. But he has a V shape, so U shape basically means that the smile is wide. In the dentition, we made a note of that infection. Because it was a sleeping infection, we call it chronical. Because it was under the root, it's the apical, and periodontitis is around the bone. Then we made a decision. We sat down with the patient and we decided on things we want to improve and things we're going to accept. So we wanted to make the smile. We wanted to make the smile wider. So we wanted to improve it. The patient was not happy with the color of the teeth. So that was one of his wish list. So we want to improve that. He was not happy with the chip, so we wanted to improve that. The black marks, he was not happy generally with his smiles. So these things were how we had to identify and offer him to improve, which he was happy to improve. The tilting we wanted to correct. And the bite relationship, there were a lot of things we wanted to correct. The dentition, we wanted to treat that infection. Like I said, we want to have a strong foundation, so we want to get rid of any infection prior to doing anything aesthetic. And the gums, we wanted to treat that so there's no bleeding. So we did a scan here, and we can see that his teeth looks like this. Then from all of the pictures, the X-rays, we married them all together, and we came with a treatment plan. And my treatment plan, generally, I like to classify into categories. First of all, emergency. The patient didn't come with any acute pain, so there was no emergency treatment required. Stabilization. We wanted to get rid of any infection, we want to stabilize the teeth, so we put some fluoride varnish. Fluoride varnish is basically a higher concentration of fluoride compared to toothpaste that we apply in the tooth to fight against any kind of cavities that can occur due to lack of brushing, higher intake of sweets, fizzy drinks, pop cola, and obviously cakes. We did a scan. We referred him to the dental therapist to improve his oral hygiene so we can get that gum which was currently inflamed to a healthy state. Brushing technique. By default, people like to put the brush parallel to the teeth, but they don't understand that the most of the plaque, which is the way of saying bacteria in your mouth, basically reside where the pink and neck of the teeth, where the pink and the white tissue meet together. So we wanted to ensure the patient knows how to brush and then give the teeth a good clean. In terms of restorative, we referred him to the endodontist to treat that infection with a root canal. And thereafter, once that was all done, they came back to me where I worked on the Invisalign aspect, the aesthetic aspect, which I like to divide into three categories. I call it the A, B, C concept. A, for lining, which we use Invisalign. B, which is bleaching, for what we call, which you use boutique whitening. And C is for contouring. In this case, we use composite. Contouring could be crowns. Contouring can be done through indirect restoration, such as veneers, crowns, like I mentioned earlier. It could even be bridges and implants. The maintenance phase is after all the orthodontic treatment. How do we maintain that? So we had a discussion from the outset again that we can do the treatment. However, there's a higher chance of relapse if we do not wear our retainers. What are retainers? Retainers are passive aligners that help to hold the teeth in its new position. And the protocol for this is I ask my patient to wear their aligners for the magic number 22 hours a day for the first 6 months. Thereafter, they can slowly transition into nighttime wear only. And to see the hygienist on a regular basis so we can address any kind sorry about that. We can address any kind of bleeding gums at an earlier stage. I'm losing my voice there. That's a water. So then, in terms of the alignment, when we do an Invisalign, I like to give a 4-step prescription to the technician at the other end. I first of all like to tell them what is the patient's main complaint, which was his smile. He was not happy with the crowding. We wanted the smile to be widened. We spoke about the gum level being out, so we wanted to get them level. Because we were doing a root canal, we wanted that to settle. We didn't want to put too much load on that tooth, so we asked them to stop the movement of the teeth up to a certain period. Again, evidence shows that if a tooth has been root canaled, or if you leave them up to 3 months, that's a good indication. You should leave them up to 3 months, to allow for the infection to heal before you do any kind of aggressive movements on them. And then I gave an anterior reference. So I wanted the teeth to move forward to widen the smile. I gave them a reference, and then I gave them a bite relationship, how much the front teeth should be vertically over the lower, which would be about 30%, which is the accepted based on smile design, and the horizontal relationship, the distance between the front and the lower teeth should be at least 3 millimeter. So this is the initial position of the teeth when the patient walked into me, and this is what we were trying to achieve at the end of the Invisalign treatment. Just to make it clear, this is only the Invisalign treatment. This has got nothing to do to make the teeth pretty. The prettiness comes at the end of the alignment. The red thing I will talk to you about later. So again, if you lie back the patient and we were looking into the patient's mouth, this is what the top arch would look like. And this is what we were trying to achieve at the end. So this was like a V shape, and this is more U, basically widening the smile. So you can see more teeth. Here we can see teeth going in. Now, if the patient again lying back and we're looking at the lower teeth, this is what we can see. This is what we can achieve if everything goes to plan. I have patients wearing their liners. For the magic number 22, they have all the buttons there. These are the buttons. In total, the teeth were aligned with over 15 weeks. We gave 15 aligners for the top and 15 aligners for the lower. The patient was seen every 4 weeks. We gave him 4 sets of aligners at every visit. And now, as promised, attachments. The red thing is what we call attachments. They are basically buttons. They are not red in color, they are white. We make it as transparent as possible because Invisalign itself is a removable, discrete, invisible appliance. And so we want the button to be invisible too. The purpose of the attachment is to make the treatment more predictable so we can move the teeth in the way we want by applying more force. Invisalign, generally, you will find that braces work on the pull concept, where Invisalign works on the push concept, so everything is being pushed. The treatment summary on the Invisalign, we didn't have to give any additional alignment. The patient was compliant. We completed the alignment in over 4 months. But the patient ensured that he was wearing it 20 plus hours, and he replaced them every 7 days. And he changed it at night time. Now, with every treatment, there's an alternative treatment. If the patient wasn't too keen on Invisalign, the alternative treatment that could be invasive or destructive could have been just a simple composite of porcelain veneers, conventional fixed orthodontics, i.e. the train tracks that we call in England. So basically brackets. We can have the lingual orthodontics, which are basic braces in the back of the teeth. Or you can have the destructive one, where you can have crowns and the various materials of crown. You can have cheaper ones, which are the porcelain fused metal. So it's a metal core with glass added on top. Or you can have glass, such as Emax or zirconia. Then we move on to the bleaching to lift the shade of the teeth. In his case, as we noticed, the teeth were darker, so we wanted to improve the shade. And for this, I started it from day 1 of the alignment. And the material that we used was boutique whitening. How does it work? So basically, when you apply the gel into the tray, and it basically diffuses through from the outer layer, which is the enamel, into the dentin, which is generally yellow, dark in color. And it lifts the shade of the shade from there by breaking down. Whitening can either be hydrogen peroxide or carbamide peroxide. Both of them break down into oxygen molecule. The only difference between hydrogen and carbamide is hydrogen breaks down into water and then an oxygen molecule, whereas carbamide first breaks down into hydrogen and then into oxygen molecules. So it's a slow process. And hydrogen peroxide is a faster process. But the outcome is exactly the same. In total, the patient used 4 syringes, and we showed him how to apply the technique. If anyone's interested in whitening, I've done a video of how to load a tray on my Instagram. You can just have a look there. So after the alignment and bleaching, this is where we reached. The teeth are nicely aligned. We have a nice relationship. There are nothing crossing over. There are no crooked teeth in the front or on the top or the lower arch, shall I say. Now, once the patient was happy with them too, then we moved on to the final stage, which we call the contouring. And in this case, we didn't want to do anything aggressive because the patient was quite young. If you imagine, if you do crowns now and something happens, it will just mean that there's only one treatment, couple of treatments left for him, implants or dentures. So we don't want to go something aggressive because people are living for in the past, these were not a problem because people had a shorter lifespan, but these days people live for longer. In the contouring, basically, we did an additive bonding, which basically means that we are not removing any of the teeth surface, so we are not damaging the teeth surface, we are just adding on top. When we do anything additive, though there is no evidence to say to use rubber dam, which is this, but it helps to keep everything isolated. So I can, as a dentist, I can just focus on the teeth I am working with. The material that we used in this case was Ivorcloud Empress BLXL, the lightest shade that you can get within composite. So that's the rubber dam. The white thing is what we call floss ties to ensure that the rubber dam stays tucked in, and then we use some clamps to support the rubber dam. And this is what we achieved after composite. Then we moved on to retention. Like I mentioned earlier, I haven't spelled the word, spelled retention correctly there. So we made, if you went for Invisalign, which is the higher end of the product, you want your retainer to be of a higher end. In this case, it was Vivera, which is produced or manufactured by Invisalign. As mentioned earlier, my protocol here was for the patient to wear it for full time for 6 months and thereafter transition into nighttime only. Alternative to Vivera, you can get Essex retainer or you can get fixed wires placed at the back of your teeth. So here is a before and there is an after. In the before, you can see the patient was actually giving a false smile. We asked him after a few pictures, after a few snaps, we had to force him to smile. Here he was just naturally smiling. This is a video. And then I like to reflect on my cases. And here, my main thing is we addressed all the chief complaints. Everything from the wish bucket of the patient was addressed, and the entire treatment was carried out holistically. We managed everything effectively, efficiently, and in a professional manner to the patient expectation. Teamwork, we basically we have a good communication with my nurses and the team, and we ensured everything was done in a timely manner. We used the therapist effectively to ensure that the patient has a nice, healthy gum, which is, you can see it's nice and pink. A healthy gum should always look pink in color. It should have stipplings like an orange skin. There should be no bleeding. That's what we wanted to achieve, and we got there. Hence why we were managed to do the composites in the end without any issues. That's it from my end. And if you've got any questions, I'm more than happy to go through it.
Thank you so much. It was very interesting, the case that you showed. So now we're going to move on to the Q&A session. So my question was, just because we don't have many international dentists that we interview,
Yes.
I was wondering if you could talk about the process into getting into dental school over there in Europe.
So in England itself, I'll touch base on the European ones. In England itself, basically, the students here, what they have to do is, when they go to, basically the first 10 years is called GCSE. They do GCSE exams, and then thereafter they do the A-levels. In the A-level, they have to attain certain grades in order to be considered for dental school, medical school. In conjunction with that, they also need to sit down for an exam, which is called the UCAS exam, and they need to attain a certain grade. What the schools do is that they look at that exam score and the grade they are predicted to achieve or have achieved, and marry them together and see if this person is a good candidate to take on, and they are interviewed the test they have to do externally is basically more to do with general knowledge, not just the subject. So they need to know overall what is the person like. And then they are interviewed. In England, there are total, don't quote me on that, in total there are about 12 dental schools, and there are about 50 places in each. So you can imagine it's quite it's a quite vigorous exam, and you need to be quite good to get into it. In Europe, basically, in Prague, where I was studying, we had many international students. They were from Middle East, there were a few from the States. We had to sit for an exam there. I did it in London. Each country has their own place for the exam. You have the exam, and then you just had a telephone conversation over Zoom, a video conversation where they just interviewed you, went through some basic questions, went through your CV, and just to get an understanding about yourself. But the main thing was how you performed in that exam. Hopefully that answered the question.
Yes, thank you. Here we have a similar process with an exam called the DAP.
Okay. Well,
so you were talking about the importance of going beyond getting your undergraduate degree. So I was wondering if you had any advice of extracurriculars or what to do to make your application stand out.
So my advice for anyone who is in school at the moment, dental school, or planning to do. So once you are in dental school, you use the first 2 years, 3 years to understand the various aspects of dentistry. Dentistry is not just looking at teeth, but some areas are to do with oral medicine, some is to do with oral surgery, and there's pediatric dentistry, restorative dentistry, there are various implant dentistry. You need just work out which area interests you the most. You don't want to be a jack of all trades, a master of none. So work out which area interests you, and then once you qualify, once you got that basic degree where you can work as a dentist, then and earn some money, then you use that money in the right way to invest in yourself, and then go into and get further knowledge into that area so you can become better. And then it makes you stand out if you understand things better. When I was at university, yes, there was not a lot of teaching because occlusion, the bite relationship, is a very big topic. And other people might have different perception or different ideas to it. I didn't think that I was taught enough of bite relationship. So when I qualified, I was like, why are these? I've done a filling, I did a really good filling, but why has it broken? So when I did my PG certification restorative dentistry, it made sense, why are these fillings breaking? Because I never considered the bite. I always just when I did a filling, I was just thought of the filling as an individual entity, never as a full arch. You need to take in consideration the frontal teeth, they are for a reason. The back teeth, they are for another reason. How are these things working together in unison? So that is things like that. I was interested in braces, so I've done some Invisalign, and I've done a diploma, so I can understand how Invisalign works. Again, whilst doing Invisalign, while moving teeth, I had some patients saying that, now that I've got a missing tooth, I want to do something about the tooth, and I was sending them out. So hold on, instead of sending those people out, why do I not invest in learning myself how implant works, so I can put everything together and I can plan things with the end result in mind?
Thank you for that advice. So I was also wondering if you have done any research while getting your degree.
In my undergrad or the postgrad?
Either one.
So undergrad, like I mentioned, I went to Prague just because I wanted that channel to be open. If I do wanted to work in the States, European countries, or somewhere else. Sorry, just have some water. With my postgrad, basically, there are many places that do implants, but the university that I chose was mainly due to the fact that where I could get not just theoretical knowledge, but practical knowledge too. Sorry.
That's fine.
So where I can get a practical knowledge too. And so I went out and looked at every place that do implants. And I looked at their syllabus, I looked at the tutors, and I chose Salford University just primarily because of the fact that I'm getting the theoretical knowledge as well as I'm getting the practical exposure, where we have a minimum of 6 implants a year. So I would strongly recommend people, the university you choose for your undergrad, for your postgrad, make sure, do your research, make sure you are getting the right exposure. It's good to get the theoretical knowledge, but if you don't have any practical knowledge or the practical experience, you will struggle.
Okay, so another question is that you were talking about how you studied in Prague, but now you're practicing in England. So I was wondering if there's any differences in the dental field that you noticed, or it's like similar.
Yes. So the reason why I came, I was born in England and I lived in England. However, when I went to Prague, and when I compared the education, my wife, she's a dentist too, and she qualified in England. So when we compared our education, dentistry in England was less medicine, more dental, whereas in Prague, with more practical aspect. Whereas in Prague, it was very theoretical based, and it was not just dentistry where we were had an eye opening to medicine. We were having exams for various medical, such as we did internal medicine. We had exams for ENT. At that time, it felt like, why on earth are we studying about the full body when we only want to we're only concentrating on the teeth? But after qualifying, after working, now I have a better understanding of how the whole body works. When people come with medication lists, I understand why this patient having this medication or that medication. In terms of practical, however, I felt like, but we lacked a bit. But that's what my residency helped me with, because then I had the exposure. I used that to my advantage, where I took time with patients and learned and went to my mentor after work, asking him questions, practicing out of hours to get better.
Okay, so another question is now about more practicing dentistry. So
yes.
Could you talk about any dental technology that you use in your practice or that you enjoy using?
So there are okay. So in terms of there are 2 ways. Let's talk about impressions. There are 2 ways to take impressions. You can either take them naturally, the old school way, where you ask your nurse or yourself. You can mix alginate, or you can take it digitally, where you just put a scanner in the patient's mouth and it scans everything for you. The advantage of using a scanner compared to the traditional is impression. So I'm just sorry, I may be slightly diverted, but when you take a traditional impression, and if someone suffers from gag reflux, boy, you're going to struggle with that, because the patient, everything that touches their mouth, they will start. There will be some kind of reflux. They won't be able to tolerate it. But the advantage now with the technology is you can do a scan and the patient doesn't have any problem, and it straight away goes to the lab. It helps to give a better impression. You don't have no work is getting lost, and everything is much better. have I gone off track here?
No, that's perfect because it explains how technology is beneficial.
And then the another thing I use now is something called Kuroko, which has recently come in the state. Previously, what the advantage I get from Kuroko is it's a tool that you can use for your notes. So when our notes is pivotal in dentistry, you need to write down everything. So if something goes wrong, you can always go back, or if someone comes to check, they look at your notes. So, and Kuroko is like an artificial intelligence tool that I use. And it basically, I've laid out everything that I do in exam or treatment. So my nurse knows, or I know that I have a set of questions that I will always go through. So I'm not losing out or forgetting something to ask. And I can't go further until I've asked those questions. So technology plays a very important role, and as a dentist, we should take full advantage of it.
Yes, I agree. So another question is, what is your favorite procedure to do?
My favorite procedure is basically doing the aesthetic work, where and seeing at the end when you give the mirror and that expression you get from the patient just makes your day, like the happiness, the smile, where a patient had before, in this case, just talking about this case, when the patient walked in, he struggled to smile. He never showed his teeth. There's pictures of him before was where we had to force him to smile. But now, if you go, you're amazed, you can't get this guy to stop smiling. He's always just, and he's built his confidence. He's got a better job. It helps. A good smile these days also helps with your personality, in attaining jobs. So the overall satisfaction you get from these treatments is just amazing.
Yeah, that's great. That's why I want to do dentistry, to make people more confident. So talking about patients, what is your approach in dealing with anxious patients?
So any patient that comes in, my first line of action is always introduce myself, my patient, my nurse, and ask the patient to sit down. We don't straight away go into the patient's mouth. We try and build a rapport with them. We try and understand. We try and understand what their likes and dislikes is, and we start to focus on the likes. We ask various questions, and if we sometimes from the body language, you can understand that the patient is anxious. So on that first day, I wouldn't do anything extensive. I would just have a chat with the patient. I wouldn't even look at the mouth. I would just ask them what are they not happy about? How would they rate their smile? What would they like to achieve at the end of it? Give them realistic goals. Like if someone comes to me and says, my current smile is, I'm going to say 4 out of 10, and I like to have 11 out of 10. At the end of it, I would have that conversation with them that what I like to do is always under promise and over deliver. I do not like to get so basically I would always be realistic to them and say, you're never going to achieve 11 out of 10, or if you want to achieve that, I'm the wrong person. I can give you 8, 9, but I cannot never give you 11 out of 10 because that's not possible. And the first meeting is always about building that trust with the patients. I like to build that trust, and you find that when a patient is anxious, and once you build that rapport with them, that trust with them, the anxiety just dissipates. They love coming back. So again, communication is key.
Yes, it's very important to build a relationship with the patient. Mm-hmm. So I don't know if we've answered this because of the anxious patients, but what do you think is the best and worst part of dentistry?
The best part is giving the confidence, building the rapport, the trust in the patient with the patient, and the worst part of dentistry is when something goes off plan and you have to break the news to the patient that actually we tried our best, but we can't give you the result that you want because of X, Y, and Z, and that's just something that you need to get. It comes with experience, and you just need to know how to bring that to the patient. You need to give them bad news. If something fails, which can fail, nothing in dentistry is going to be 100% permanent.
Yeah, I always like asking that question because nothing is ever perfect in any
No. We live in an imperfect world. How you make it imperfect into perfect, or how you can perceive it to be perfect.
So now I think this is going to be the last question. To tie it off, what made you want to become a dentist, and how did you choose your specialty? So a little like two.
Okay. So I come from a medical family background. My granddad's a doctor, was a doctor. My dad's a doctor. So we all, and my cousin, we always have friends and family all in medicine. So medicine was always, we can say, it runs in our blood. So we always wanted to do it. We were always brought up with it. However, I was never into the medicine aspect, but I wanted to do something. So, and dental, what I found with dental is you never see the same patient. You can never do the same procedure day in, day out. Like a full day would be divided into, you'll be seeing kids, you'll be seeing adults, you'll be seeing old people, young people, and people with anxiety. This is the beauty of dentistry. You're always dealing with different kind of people. So you never have a dull period. So that is, and the fact that you're doing something to improve the confidence of the people, that's the two aspects of dentistry that pull me towards it. To become a dentist. And what was the second question? Sorry.
It was, how did you choose your specialty? Like, why did you choose aesthetic and implant dentistry? Yeah. So, to be brutally honest, endo or endodontic or root canal is not my forte. I hate them, because the reason why I hate them is you can never give, the outcome is never 100%. You can, it can fail, and it does fail. Well, it fails in my hand, so that's why I don't do that. Aesthetic is because I can give a patient that confidence. I can help them with that smile that they always wanted to achieve, and seeing that happiness on a person, seeing that confidence just makes you a happier person. That's why I chose aesthetic. And you get to deal with patients from all kind of backgrounds, and who also all want different things. And because they keep you on your toes, and that's what I like about it. Why do implants? Implants basically, again, it's something coming from it's part of surgery. You can say that I like to see that blood. It's just got that feeling to it, and that's why I chose implant dentistry, where you can give something. You're dealing with blood, you're dealing with some surgery. At the same time, you're able to give something that is as natural as a tooth. Well, thank you so much. That's the end of the Q&A and the session. I wanted to thank you again for all your advice, and it was very interesting learning about a case, like step by step.
Thank you for having me, and hopefully I have answered all questions, and I've given a good insight into dentistry, and you can take on board my advice. Like I said, those advice are from my own personal experience. It's not right or wrong. It's just my own experience, and if you can get something out of it, the main thing I would like to wrap up things with is communication. Always remember, communication is vital. It's pivotal to succeed in dentistry, or anything actually.